Live from New York, it's Benefits with Friend. I am your host, Lou Bernardi. Thursday, March the 16th. Welcome. Beautiful day in New York, actually. Not the norm for a Thursday. So thank you very much for anybody who might be attending the live event. Ahead of the podcast. We have I think a really interesting, great topic and guest today. Korb Matosich, and I'm going to ask him if I said it when I bring him in. Hopefully I said that right. But he is the co-founder, CEO, and board member on Asserta Health, which is this is something that is cash pay type model. I'm going to let him in. I'm going to bring him right in. Here we go. Korb, welcome.
Hello. Thank you very much for having me. Appreciate it.
Thank you very much. This isn't Hollywood or really a live TV broadcast, so there's not a lot of slides and things like that. So I started to introduce you, but I want you to be the one that kind of introduces what Asserta Health is. Talk about your background a little bit, because I think that's really interesting and brings a lot more kind of clarity and validity to the conversation today. What you've seen, where you've been, and how you got to where you are today. So
wonderful. Well, so my background is that I've been in healthcare for the last 20 years or so, ever since I got out of graduate school. And the entirety of my healthcare career has been focused on the exciting topic of healthcare payment, which, people love to talk about. Life of every cocktail party. I actually started my healthcare career at a company called Ingenix, which is now known as Optum, part of the UnitedHealth Group family of companies. And even though I was part of UnitedHealth Group, I started on the provider side of things, working I actually managed their revenue cycle management business, and did that for several years, working with large provider organizations to accelerate their revenue cycle, accelerate their payments. And then after doing that for several years, I was asked to switch sides, so to speak, and I took over their payment integrity operations. So I was still at Ingenix, but now managing the flip side of the coin, so paying claims. And, obviously got to see healthcare payment from all angles, from a provider perspective, from a payer perspective, arrived at the, horribly obvious conclusion that healthcare payment doesn't work very well. I think anybody that's paying attention can easily conclude that. Also came to the conclusion that it can be better, that it can be different. And most people, when they think about healthcare payment, they don't believe that. They believe that the entrenched third-party claims-based reimbursement model is all that there can ever be. And Asserta Health was founded and created to deliver a better way to pay for healthcare. And what we do is facilitate immediate cash payment for healthcare services. Basically, we're trying to create a more retail-like purchasing model where price points are understood in advance, but providers are also paid when they deliver services.
For the audience out there, might be CEOs, might be HR directors. I know that there's other people in the industry, advisors, brokers, maybe carrier reps, things like that. For a very long time, because of the business model of healthcare and health insurance, the consumers, right, the employer plan sponsors and their employees that become patients when they enter the healthcare system. This is just all happening behind the scenes, right? Why is this even important? But, having been in the industry for 30 years and understanding, I started, I don't know if when we spoke, if we kind of got to this previously, but so out of college, I rec a lot of industry. So in '89, when I graduated from St. John's University with a finance degree, it was in the wake of the Wall Street crash of '88. So I thought I was going to be in finance, stocks. I was going to make it big. But instead, I took a left turn and I ended up at a really large radiology practice in New York, working in the controller's office. And there were 4 of us, and we did everything. We did medical billing, we did claims, we collected the receipts. Back then, most people paid by check or cash, believe it or not. For MRIs that were at the time, several $100s. They were getting more and more expensive. They had a captive audience of people coming every day. And even back then, as a 24, 25-year-old, I didn't like what I saw. I saw what I perceived as abuse. Like I was calling collections on people who And there's a chapter in my book that, if it ever comes out, it talks about like these weren't people who, in my mind back then, having kind of really just reached adulthood, they weren't deadbeats. These were people that wanted to pay their bills. They were embarrassed by not being able to pay the bills. But even back then, this was pre-managed care. There were no networks at the time. This were indemnity plans, a lot of Medicare patients, things like that. They were struggling to pay what was still an unexpected bill at the time, right? They didn't know. And many of the people were there, in my estimation, didn't need to be there. These were deals that doctors were making and said, yeah, we're going to funnel our patients there, and they're probably getting kickbacks. But, it really shed some light for me on the medical billing part of it, because the doctors were doing really well, but there was still a really significant amount out in collections that they were never going to collect, or if they were, it was going to be pennies on the dollar. So it was a big problem even 30 years ago. And the patient, right? The patient relied on what the insurance company approved. They didn't know what that dollar amount was ahead of time. They got an EOB, which was, even back then, probably a little bit less complicated than today, but here's what it costs. This is what we approved. This is what we allowed. This is what your plan paid. And this is your responsibility. And, that process has not gone away. Managed care has probably escalated the amount that's out in collections today, because the pay more, get less every year cycle of watering down the benefits, increasing out-of-pocket cost on members, has resulted in people walking around with HSA style or HRA style plans, high deductible plans, with no way of paying that out-of-pocket cost if it comes up on them unexpectedly, right? They know what they can afford. There's a lot of education involved in maybe making the right plan selection at open enrollment. But so you've seen behind the scenes how that has impacted really both sides, right? The payers and from the insurance carrier standpoint, like, their process in that. Have you seen, so you're doing this for 20 years, which is right around the time, what was that, 2000? So managed care was here about 10 years at that point, right? Still pretty low by today's standards, pretty low out-of-pocket cost for most people.
Sure.
It was right around the ACA, so a lot of the ACA mandates hadn't really hit home yet. So, so you did that for how long? How long what dates are we talking about, from like around 2000 till when?
Well, so yeah, I mean, it was actually 2003 to about 2011 was the rough time frame that I was focused on more traditional healthcare payments. So again, revenue cycle management for providers and payment integrity for payers, and it was in kind of the middle of all of that for that time period.
So when you say payment integrity for the payers, right? So you're talking about the insurers, correct?
Correct.
I'm assuming that was even more. So something called medical loss ratio, which I'm sure you're probably familiar with. But if you're out there and you're not familiar with medical loss ratio, it's a component of the Affordable Care Act, Obamacare, that basically changed the math in the way insurance carriers manage their profits. There was a time pre-ACA where you could argue the less the insurance carrier paid out, the more revenue they kept, right? They collected $1 billion in premium. That's a small number, but I'm just using that. And they paid out half of that. They had $500 million in profit. But under the Affordable Care Act, medical loss ratio basically caps their earnings percentage on a percentage of billed premium. So you could argue that the insurance carriers have no incentive today to pay out less. They actually want to.
No, they have an incentive for their profits to go up. The only way that their profits can go up, since it's basically a fixed percentage of premium, is the only way profits go up is if premium goes up.
Right, and the only way premium can go up is if claims go up. So they have to pay more to justify the higher premiums, especially in the small group market, which is typically under 50, under 100, a huge component of the industry, because most businesses by volume are that.
Small, right? Yeah.
Right? Large group, it's a little bit more complicated. But so did you see that shift? Were you conscious of the fact that payer integrity, did it change in any way around 2010, 2011?
I mean, the visible face of it didn't, you know, but in my opinion, and other, kind of similarly experienced industry folk would, I think, confirm this perspective. Payment integrity activities have been communicated by major carriers to be taking place for, as long as I've been in the industry, certainly predating me.
Mm-hmm.
And they would claim, we do all of these activities, but when push comes to shove, the carrier is much more concerned about safeguarding its money. So it is much more methodical and careful about managing fully insured business than, for example, self-funded business, right? Because they do keep it, and they keep more of the profits, as it were.
Sure.
A self-funded plan, if you save the self-funded plan a lot of money, you're benefiting your client,
right?
And I don't want to make it sound like they're intentionally trying to defraud their client. I'm not.
No, absolutely not.
I'm definitely not making that claim, but I am claiming that they're not that concerned about protecting other folks' money. They're much more concerned about protecting their money, and it doesn't really have anything to do with payment integrity. But one thing about network contracting, I mean, this is probably not commonly known, but if you look at any major network, there's not a network price. There's multiple network prices, and they keep the best one for themselves. And then there's various tiering. And so as an ASO client with a carrier, it's great that you get access to the United network or the Cigna network or what have you. But rest assured, you're not getting their best discount. They're keeping that for themselves, and they've worked with the hospitals to trade off. We're going to get you paid more with these other folks and their money, and then when we're paying the bills, we're going to pay you less. I mean, that's a very real dynamic, and that dynamic plays out across the broad spectrum of their responsibility for paying. Like they are safeguarding their interests first, sure, and your interests secondarily.
Well, from a fiduciary standpoint, insurance carriers have a responsibility to their shareholders at the end of the day. Obviously, they have to have the perception of working in the best interest of their client, and they do in many ways, right? They do. This isn't a bashing. The show isn't about bashing insurance companies. It's about educating the consumer, right? The employer plan sponsors, the patients, the employees of businesses, that when they go to select their health insurance plan, so they can make a more informed decision. And I think what really is so crucial to me is the fact that you're paying as an employer, you're paying a tremendous amount of money. You should have a better understanding of how that money is being spent, where it's being spent, and you should really insist on having access to that data, right? Access to what are you paying for MRIs, CAT scans, which kind of, gets us to, so let's talk about Asserta Health for a second, because that was a great, background to explain really what you've seen, everything that you've seen, and how, what a credible, person you are to talk about the approach that Asserta Health does. And, this isn't an advertisement for Asserta Health, but this is a really interesting, I call it, I tell people all the time, there is an entire separate universe of healthcare and health insurance out there that it doesn't get to most employers. They don't see what's happening behind the scenes, how the healthcare systems are. When I say healthcare system, I'm not talking about the hospital systems, because that's another problem. Doctors, the practitioners, the ones that, especially the independent ones that are struggling to stay competitive, stay independent, and provide a real value to their communities. So introduce Asserta Health. I want to kind of shift into that conversation for a second.
Yeah, and one thing, just before I introduce Asserta Health more thoroughly, you mentioned a very important word about fiduciary and you did it in the context of the carriers have the fiduciary responsibility to their shareholders. Well, the plan sponsors have a fiduciary responsibility to their plan members. And candidly, to a large extent, that has been ignored historically. And one of the trends that I think we are going to see here in short order is that the type of lawsuits that held 401k plans accountable in the early 2000s are going to come to health plans. And, and employers are going to be held accountable by the folks that whose money they're taking, right? Because their employees are contributing in most instances, right, to the funding of their care, and they're going to be held accountable for how those assets are spent. And I would make the argument that just going with the PPO network is not a good use of your fiduciary, or not a good way to execute your fiduciary responsibility. You're going to have to be more thoughtful. You're going to have to be more careful.
Well, so we'll take a time out for a second before we talk about Asserta, because that's a great point. And last week we actually the show got canceled, but I was going to have someone a guest on, which we'll have on again real soon. But he's from the pension side of the industry, right? So not healthcare. We're health and wellness experts. He's a pension expert, and he's lived through the compliance nightmares, lawsuits, fiduciary responsibility. And it's important for the plan sponsor. When we say plan sponsor, we mean employer that is offering a health insurance plan to their employees, just to be clear. The Department of Justice, the Department of Labor, the IRS, all of these entities who are involved in all these compliance and like regulations that a lot of times the plan sponsor isn't even aware of these regulations, because the people who they entrust with their health and welfare plans aren't responsible for these things. So we know right now the Department of Justice is looking really heavily into pharmacy benefit managers, PBMs. And what they do is pretty despicable, I think, to drive up prices, drug costs, which are literally killing people because they can't fill their prescriptions, right? To the tune of, my estimation is 100% markup at the end of the day with rebates and spread pricing. They can make them accountable for their business practices, but the regulators are going to come down on the plan sponsor because they cannot mandate a third party to do something. Yeah. Right. So if you're the plan sponsor and you're going out there and you're purchasing a health insurance plan, it's kind of buyer beware now, because we know, and you cannot pretend to just be ignorant and pretend that you are not hearing that insurance carrier discounts are complete smoke and mirror game. They're not getting the best prices. Could they? Yes, they have the leverage to do it, but it's not in their best interest to do it. It's not in their best interest, and we talked about that a little bit before with the medical loss ratio. Yeah, it's not your insurance carrier's best interest to get you the best price for prescriptions, for radiology service. It's not in their best interest to guide members to the highest quality care, so they don't. Right?
That's correct.
And so this is really important, and hopefully ears will go up when HR directors and CEOs who sign the 5500s, that's going to be the person with the fiduciary responsibility at your company. And you just cannot blindly follow the status quo anymore. I'm not saying fire your broker. I'm saying educate yourself enough so that you know the right questions to ask, so that you're getting the guidance that you need to find the most affordable access to healthcare for your employees, and then fund it in a responsible way. That's in essence. Self-insurance is a great option, but it's not for everybody. Fully insured can be a great option. High deductible health plans could be a great solution if they're structured properly. But at the end of the day, we're talking about, trillions of dollars that are spent on healthcare, and a lot of very upset people. And if you have an employee who feels like you've been irresponsible, just like on a pension plan that has excessive fees, and you haven't looked at it in the last 3 years, you better do your due diligence, because there's a good chance that you're going to be audited and potentially significantly fined. So anyway, that was a great kind of segue. So tell me about Asserta Health.
So Asserta Health, again, kind of based on this background in payment, is focused on enabling a different payment model for healthcare. And again, what we aim to do is facilitate a retail-like purchasing model where price points are understood in advance and providers are paid as they deliver services. We have a fundamental hypothesis that went into our founding, which is unless we pay for healthcare differently, it will never be affordable. You have to pay for this service differently to bring the cost down. And what Asserta Health enables is immediate cash payment for healthcare. So we have a proprietary payment platform called medEcash that allows us to stage money from an employer, from their plan members, and then pay providers as they deliver services. And it really creates a much more direct path for the administration of healthcare. So instead of, and again, I already used this term, it's even hard to say, right? Third-party claims-based reimbursement. It's, nothing should be that complicated. It's just pay for care, pay for, understand what you're paying and pay for it when you deliver it. Providers should be taken out of the billing business, and they should receive payment when they deliver services, and that's what we enable.
So, and even before they deliver services, potentially, right? I mean, if you have,
yeah.
So I'll give some examples of what we've seen price wise, right? So again, insurance carriers 30 years ago, when managed care really started entering the market and put all the indemnity plans out of business, the pricing structure of healthcare was still pretty standardized, right? There was a price. Doctors had a price for things. Hospitals had a price for things. Networks didn't exist. All these discounts, and when you think about that, it was simple. You were getting a true discount. If the insurance carrier was getting a 25, 40, 50% discount, that was a true discount because the healthcare systems hadn't had chance yet to fight back. But they realized that they're getting beat up. They're losing money, right? The revenue was down, and they needed the market, the health insurance marketplace, very quickly and swiftly turned into managed care. So if they wanted patients, they had to be part of these networks. There were very few exceptions to that. Very few hospitals that could survive without getting payments, and people with the popular network in that area, because a lot of them were very local, back in the day as well. You didn't have these seamless national networks that you have today with Aetna and Cigna and Empire. They were building them out, but they were local. And the hospitals got together because they're the biggest, right? These are the biggest entities within the healthcare systems. Back then, mostly independent. And they said, wait, we're getting beat up over the head. We're going to have to come together. We're going to have to merge, horizontally with other hospitals in order to have the leverage to get higher reimbursement, either a lower discount or the ability to inflate the price, which is what happened, right? The prices started becoming much more complex. If you wanted $2,000 for a service and the insurance company is getting a 50% discount, you had to charge $4,000 for it. But maybe the other insurance company is only getting a 30% discount, so you could charge less. So that's where this whole pricing model just got ridiculously complex because it's not the actual price and it's not the cost, it's the net price and the discount, right? So it's how much do we want to get? How much are we willing to pay or overpay for this? And that's where the pricing model of healthcare got so out of whack and so complex. I mean, if you go on any health insurance carrier's website today and you go to do a doctor search, there's as many as 40, 50 different networks, names. I'm not going to mention any insurance carriers, but there's some that's like, oh my God, there's 50 different choices of network. Which is my network? I don't even know which one. So even from within one carrier, as you mentioned, there could be thousands of different pricing models. I mean, it's really pretty insane. And then, of course, the healthcare system started merging vertically. They realized, wow, this is going pretty well for us. What if we took over the labs and the radiologists and the urgent care and the specialists and got them all under an umbrella? We could even negotiate better prices from the insurance companies. And that's where we sit today, is these monstrous, I guess monopolies aren't illegal anymore, because when I was young and going to St. John's, monopoly was a big deal, right? I mean, that was a big deal. Doesn't seem like that applies to healthcare. They've allowed this to go on, which is why it becomes so much more complex to unwrap these huge prices. So now you develop a cash pay model. Why does that benefit the doctor? Like, why ultimately would a provider say, "Yeah, I'll take that"?
Well, I mean, it's beneficial because the administrative cost of the third-party claims-based reimbursement system is exceptionally high.
Sure.
And many folks say it's 25%, right? So we've got a north of a $4 trillion system, and we're spending 25% on administration. I mean, how can that make any sense, right? So, a doctor's office resents insurance companies for the most part, and they're frustrated with the process. And in our model, you just get paid.
So they get paid, which is good. There's really, I'm assuming, no balance billing in many cases, right? It's a cash price.
It's a mutually agreed upon payment. Yeah.
So it benefits the patient as well. Are you eliminating or just lowering the patient's responsibility in this case?
Depends on the client. We do have a number of employer-sponsored health plans where, using our model, they have eliminated both all premium contributions and all out-of-pocket costs, and the plan is performing better than it used to, right? Mm-hmm. Because if you do things in a responsible manner, in a thoughtful, kind of purchasing manner, you can get a much better value. I mean, it's kind of funny in that healthcare has become one of the largest expenses on an employer's P&L. They would never think about managing, their sourcing of raw materials if they're a manufacturer, or other inputs to their business in the way they do healthcare. Like that they consider that to be a core function of their business, and they actively and strategically manage it. And then all too often, they'll just go to their consultant and say, "What should I do?" And we need more kind of thoughtful engagement by an employer about what's the best way to deploy, these resources and get better value for our money.
Which is the beautiful thing, it's intentionally complex, and that's if I was an HR director out there and I'm hearing about this for the first time, I'm like, wow, that it could be intimidating, right? Because businesses gave up after 25 to 30 years of perpetual pay more, get less, pay more, get less. There's nothing you can do about it. All of the false narratives, like the claims are the claims, right? Because of the gag orders, because of the deliberate, the deliberate process of not giving the data to the consumer, they were able to perpetrate all of these narratives, which is, there's nothing you can do about it. The cost of healthcare just goes up 10% every year. They invented this word, this thought of medical trend, and it just beat people up. So I've had CEOs tell me, because I've challenged them, and I don't like doing that, but I feel like it's my job to say, hey, as you mentioned, this is a top 2 or 3 business expense for most medium-sized to large companies. It is a really tremendous tool in their recruiting process, right? You got to remember that, I remind people all the time, before the Affordable Care Act, there was no mandate. You didn't have to do this. You didn't have to offer health insurance. A lot of people thought you did, but it was just, again, normal business practice. So they have this huge red on their, financial statements. They don't think there's anything that they can do about it. Every single partner that they have involved with the process, their benefits partners, makes more money when your price goes up. Your broker makes more. If there's a general agent, the general agent makes more. Of course, the healthcare system makes more, and the insurance system makes more. There's no one who wants the cost to go down 25%.
Yeah, I mean, it's all about incentives, right? It's all about incentives and how people respond to them. And I don't want to, badmouth any one party here, but I would like to talk about brokers, for example. And I want to distinguish brokers from what I think of as benefits consultants. And maybe that's just a distinction in my mind, but one tends to be more, I'm a fee-based consultant. My client pays me for my services, and my goal, my only incentive is to provide them good services so that they continue to pay me my fee. A broker is generally commission-based, and you got to be thoughtful about this. I guess it's great that you don't have to pay your broker for their services, but if you're not paying them, who is? And then who is that broker loyal to? Sure. And because a lot of brokers, because I'll have this discussion. They'll say, "Hey, don't badmouth brokers. We're not a significant percentage of the total cost of the industry," and I'll grant them that they're not the whole reason why costs are going up. But and I guess I need to be a little cautious here, but many brokers have sold out their clients for that small amount of money in terms of the grand total that they're paid, or the grand total paid for healthcare. They've sold out their clients because they're not helping their clients make decisions that are in their best interest. They are driven by their commissions, and they are basically, most brokers are outsourced sales representatives for the carriers. And as an employer, you need to understand that this is not somebody that, again, their primary concern is safeguarding your interests. You're not paying them. The carrier is paying them. And they are looking after the carrier interests because that's who's funding their business.
Yeah, as someone, so I talk about it occasionally, but I was a general agent for 25 years, from 92 till the end of 2016. I was the broker's broker, right? Most brokers that I worked with, and there were hundreds, if not thousands, over the years, they did other things. They were investment specialists. They were life insurance brokers. They were disability brokers. They were, property casualty brokers. But they had clients, and the clients were buying insurance from them. And that's the thing. Most brokers are selling an insurance product. It's pretty simple, right? It's a simple. Even though it's complex, it's simple. It's a number. It's a premium. So it's the simplicity of that fully insured product that you're buying from your insurance broker that's relatively standardized, right? I mean, the terminology from one company to another, you got co-pays, you got co-insurance, you got deductibles, you got out-of-pocket costs. Here's the network. The network is king. That's why the consumer, that's what they decided. Network's the most important thing. We'll even pay a little bit more for a larger network, which made the insurance carriers grow networks. But the brokers are selling a product that they're I would say most, at least in the small group, under 500 segment of the population, right? There's really large consulting firms, and I'm not saying anything good or bad about them, but in the small group marketplace, you have a broker who's selling you a product that you're asking for. They're selling to the expectations of their customer, and the customer, does not have much information to go by because they have been sold a narrative that is untrue. They've been sold that insurance protects me from the cost of healthcare for my employees. I'm getting the best prices, right? There's no reason why carrier A, who also owns or is owned by the pharmacy benefit middleman, the broker for prescriptions, and is also becoming the healthcare system, there's no reason why they can't get the best prices, as I mentioned before, but they're not. The numbers do not lie. And that's what most employers aren't aware of these days, is that there's an abundance of data. You're just not seeing it. Yeah. The insurance carriers always had the data, right? The data is what tells them what to do, how to maximize their profits, the type of products to build. The healthcare system sees the data. And there are signs that both of those entities, the biggest lobbying groups and the biggest revenue generating economies within our economy, healthcare and health insurance are the two largest industries within our healthcare, within the entire U.S. economy. There's not even a close.
Yeah, I mean, it's bigger than most other countries' economies.
Absolutely. So, we have these two huge forces that have had the benefit of being able to keep the consumer in the dark. Now we have legislation, price transparency, benefit compensation, disclosures, all a mandate on the employer. Right now, what we're going through, and I guess the deadline just passed, was every employer in the country technically is responsible for submitting their pharmacy data from the last 2 years that they've never even seen or even have access to. So all the insurance carriers are jumping in voluntarily and saying, we'll take care of that for you. We don't want you to see this data. This is the last thing we want you to see. So we have all of our consumers, all of our customers that are fully insured, that are authorizing the insurance carriers to submit the data for them, which is unfortunate. We want the data. We want to be able to show them the prices. So now, getting back to what you guys do. So the consumer can understand the cost of an MRI here on Long Island, the cost for the hospital to perform the MRI, self-reported, which they have to do for Medicare, is about $200 or less.
Right.
What it costs them to perform it. That's the technician, the electricity, the room in the building, their little square footprint, whatever, about $200. The worst price that I've seen, or the highest disgusting price I've seen, is $7,000. That's the price. The insurance carriers will pay about half that. So paying $3,500 with your money, the employer's money, for an MRI that costs $200 that you could get a mile away at an independent facility for $600 to $800. And if you pay cash, you could probably get it for less, which is because cash is still king. As you mentioned before, when you're getting cash, you don't have to worry about billing that person necessarily. Maybe there still is a $100 out-of-pocket cost, but it's going to be significantly less to the member, I'm sure, if you're billing the plan appropriately. And then the overhead to the doctor. Collections, medical debt is 70% of all bankruptcies are medical debt related. And that means those doctors are never collecting that money, but they're paying a ridiculous amount of admin cost to try to collect it, right? So the future of healthcare, I think, will be cash. I don't think
that's certainly what we're advocating for. And the world that I would like to live in, and I need to acknowledge we're a long way away from it still, but I would love to live in a world where providers, like every other business in the country, advertises their prices, right? They basically say, here's our price point. And then also shares information about their quality. So one other dynamic here in healthcare is because providers are not competing on price, they intentionally hide quality information. They would much rather that you just focus on their brand, right? They want to be able to market and say, we're the best health system, come to us for everything. But the reality of the matter is that every health system is good at some things and not so good at others. But until health systems compete on price, they will not also compete on quality. The two will go hand in hand. And the world that we would like to see is one where providers are paid promptly and fully. Their administrative side of their business is greatly simplified, but they are competing for business the way that every other business has to compete. They have to provide a high value service, which means they have to deliver good quality at a reasonable price.
So one of my season 1 guests, my 9th show, is Dr. Jonathan Kaplan. And if you're not connected with him, I should connect the two of you, because he just said exactly what he's trying to build. He's a plastic surgeon, right? And plastic surgeons, as most people know, right, a lot of that is elective surgery. It's not covered by insurance. So he built a system called Build My Health, which is a platform where doctors can use his technology and advertise their prices for their care, bid on care, right? I use the analogy Amazon, right? So Amazon, you probably heard of it, right? It's spreading.
Yes.
But it didn't exist that long ago, right? If you think about, I don't know what year Amazon came, but there was a time before Amazon where people had a difficult time shopping for the things that are getting. That white truck that's driving around my neighborhood from dusk to dawn every day is delivering products from a vendor, good or bad. I'm not here to talk about that, that makes it easy to shop. You can see the price. You can compare the price. You know when it's going to get there. You can see the reviews. You can see similar prices. That's why in healthcare, especially high quality healthcare, is a little bit more important than your next pair of jeans. And I ask people all the time, knock on wood, if something serious happened, a sudden illness or injury happened to your loved one, because people care more about their loved ones than themselves most of the time, where would you go for care? How would you find? Well, first of all, would you want to find the best doctor? Of course, everybody's going to say yes. Nah, any doctor's fine. I need a transplant. No. How are you going to find that? How do you know that the doctor whose table you're going to be on is the best doctor for you in that instance? Because we could be talking life or death. And when you talk about it like that, it's pretty scary, right? Yeah. And hopefully most people won't be in that situation, but you could be very suddenly. And you deserve to know it is not right for the healthcare systems and the health insurers to keep that from us. They know who the best doctors are. They absolutely know. The data does not lie. And it's not the doctor that does the most procedures necessarily. It's the doctor who does the adequate number so that they have the experience, but has the best outcomes. Their patients recover the best. They don't need opioids for the pain unless that's absolutely something that's going to come with it. I mean, there's all exceptions. And the doctor's just as important as the hospital you're in. There's hospitals that have great reputations, but inside that hospital, there's good and bad doctors, right? You want the best doctor at the best hospital, ideally. At the worst case scenario, you want the best doctor at a pretty adequate hospital.
Agreed. Well, and that's definitely, I mean, if you have to choose, I would choose a high quality surgeon in an average hospital any day over a theoretically high quality facility and an average surgeon. But, ideally you want to put the two together, and, the dynamic that exists today, though, exists intentionally, right? Those health systems are pretty aware in most instances who their good docs are and who their bad docs are, but they're not about to tell you. And by definition, right, people forget this. By definition, half of doctors are below average, right? I mean, think about that for a second, right? And do you have any idea which half are below average? Because that's who everybody should be steering clear of, obviously, right. But that is very deliberately opaque today.
Well, it's like any industry, right? The best salesman might be the one with the most honest salesman. Like, I would want an honest salesman, but the best salesman to the organization he works for might be the guy who brings in the most revenue in most cases. Yeah. Doesn't mean they're the best salesman. Maybe they have a lower, threshold for maybe line to bit. Like, who knows, right? In any industry. But again, healthcare is very different than anything else that we shop for as consumers. And it is despicable that the regulations that are imposed on retailers, for example, significant penalties for not posting the accurate price on the shelves, right under the product. It can't even be offline a little bit. Your Campbell soup, it's in the wrong spot. Technically, you could get like a $10,000 fine for that. And probably not happening very often, but why not healthcare, right? So you got to wonder the forces at work, right? The forces, the lobbying, the money that's at work. The consumer still is king. So getting back to Asserta, because I'm really interested, because we're talking about quality.
Yeah.
So when you guys are reaching out to providers, would you? I'm going to assume that the quality of the doctor is also just as critical as getting the best cash price. That you wouldn't be sending someone, in theory, you wouldn't want to.
If we are sending, quality matters. And the reason why I say that is many of our clients, their employees and plan members present to us saying, I want to see this doctor. And when they tell us that, we don't try and convince them to go somewhere else. We tried that earlier in our history and it didn't go very well. Choosing a doctor is an emotional decision, and arguing with someone about the quality of the physician that they've selected is generally not a good use of time and resources. But when people are looking for us to steer to care, we look at outcomes. That's our primary driver, and we steer to outcomes. And yes, what we do as a matter of practice is combine high quality with affordability, and you need both. You don't want just one or the other. And that's even true. I mean, there are a number of vendors out there that say, well, it's all about quality. If you just get the highest quality, costs will come into line. It's patently false. It's clearly not true. I mean, and I would say in any equivalent situation, quality actually tends to cost less than a lack of quality, but just going to the highest quality without any consideration for price is not a good strategy.
No, and why should it be, right? Because in any other type of product, you pay, hopefully, sometimes it's maybe undeserved, but hopefully you pay for what you get in some cases, right? Obviously, we want to get the best price. You want to get the best price, but you want to get to the best doctor. For me, that's at the core of it. So that's really important for me, because like when we're constructing, when we're developing our approach to our customers' plans, there's a lot of different pieces that are really crucial that they connect and work seamlessly. And a lot of times, plan sponsors don't realize your card might say Aetna or United or Cigna or Blue Cross. There's dozens of companies behind the scenes, a lot of them under the same umbrella ownership of the carrier, but dozens of other outsourced vendors, third parties. So we're doing the same thing. We're just trying to pick the best in class solutions that have aligned incentives with the consumer. So we have case management, concierge healthcare, right? That's the part where a pre-certification comes in for an MRI or surgery, a specialty medication, an injectable medication, things of that nature. That's our time, not me. I'm not making the phone call. For our partner to say, time out for a second. We want to make sure that we have a plan that's designed so that we make outreach to that member immediately and say, we're here, we got your back. Would you like us to refer you to a high quality provider? Would you like some guidance in that? Do you have someone? And sometimes, like you said, they share the name of no, my doctor wants us to go here. Okay, that's fine. We're not in the business of telling them no, but we are in the business of sharing that. Okay, well, let's take a look at it and say, oh, doctor's great. That's at the, that doctor's in the 70th percentile. That doctor's in the 40th percentile. Just out of curiosity, would you want to know who the best doctor in the area is for that? And most people, when you take that approach, aren't going to say, no, I'm okay with my 10-year-old son going to a pretty good doctor. You pique their curiosity, but you've also you have to be understanding that people don't think that this exists. People don't think that there's anybody to help them. They've been going it alone for so long and just blindly following the system and getting these outlandish bills after the fact for so long that they just think that's what it is. They don't know that there's companies like Asserta or Engaged Health or independent pharmacy benefit managers that are 1/100th the size of the biggest players in the industry that get better prices because they can, right? They just don't know that there's someone who's actually got their back. We actually had a member call an HR director because of outreach. So when we have, you probably come across this. So the nurse practitioner or the concierge, advocate will usually reach out to us and the HR director and say, hey, could you give John Doe a heads up? We're reaching out because we know that this isn't normal. They're not used to getting a call from their insurance partner, right? It happens months later a lot of times. We just want to make sure that they understand that this is an added value of your plan. We want to reach out to them. We're not looking to change any minds, but we are looking to educate. We are looking to be an advocate for them. We are looking to make sure that they have all of the information they need to make an informed decision that's in the best interest of themselves, both financially and from a health standpoint. The employer can't dispute that either, because the employer wants their employee back. Even if it's not an employee that's going for some sort of treatment, I know that if it's one of my loved ones, I might still be at work, but my mind's somewhere else, right? My mind's not there. I want the best chance of success, a speedy recovery, least amount of care after the fact, if that's possible, no infection. I mean, I've just heard stories. We could talk about that forever. So how from the time that you started this company, have you seen in the last few years just an escalation in doctors, especially that are interested to learn more about your model?
Yeah, the marketplace is changing. Although, to be clear, it's I mean, doctors are obviously vitally important to the system, but costs are not driven by doctors.
Right.
They're driven by hospitals and facilities and
yeah, that's kind of what I meant when I said doc. Yeah, I probably shouldn't have said doc. And I want to talk about that actually before you finish your thought. We're not talking about every single procedure, every single claim, right? We're talking about.
Well, we will be. We will be in the future. I mean,
see that.
we're taking it in that direction, but the logical place for an employer to start is with high cost services. And what people don't understand is that the regulatory environment has changed, and specifically the Consolidated Appropriations Act, and there's no surprises provisions that are related to that, have really strengthened the position for cash payment. And any employer health plan, irrespective of the carrier that they are with presently, as long as they're self-funded, that is the caveat. If they're fully insured, they couldn't do this. But any self-funded health plan can implement a cash payment program alongside their current plan, with minimal risk, lots of upside, and an opportunity to begin changing the way that you pay for healthcare. Because most employers are not going to be prepared to go wholesale. I've been using my PPO network, and that's what my people are accustomed to, and we're going to just go cold turkey over to a cash pay world. Some are doing that, but most are going to want to dip their toe in the water. And people just need to understand that in the current regulatory environment, you have a right to do that, and there's lots of protections around the patient or your employee or their dependents because of the current regulations.
So you just touched on something, and I think that maybe when we spoke previously, you had mentioned this to me, and if you can elaborate on it. But just because you have coverage with a network on your ID card doesn't mean you have to use it.
No, you have a right to privacy. You have a right to privacy, and the Department of Health and Human Services has even published guidelines around this. Each individual has the right to choose whether or not to report their insurance. Now, what's funny is a lot of hospitals will say, if you have your insurance and you don't use it, you're breaking the law. That is patently false. Again, that is absolutely untrue. The law is actually the opposite, which is you have a right to privacy. You can choose whether you want to use your insurance or whether you want to pay cash. What our technology facilitates is an individual paying cash, but using their employer's money. So everybody's better off, right? So you're not reporting your insurance. Your employer, who's ultimately paying your healthcare for your healthcare anyway, why not pay more directly, more efficiently, get a better price for the same service?
And so when you say you have a right, when does that right end? So I go to I'm going to have a procedure, right? Something that you have the ability, Asserta Health has the ability to intervene on. When I leave there, like, is it something that has to happen? Can I get my EOB 3 weeks later, in other words, and say, oh, I don't want to pay that, right?
No, to do what we're describing, you have to be able to pay at the time of service.
Right. And that's the important thing, right? You don't have I'm talking about the legal right for that patient to pay using a cash price expires after the service and you leave.
Well, at least the clarity around it expires. There are actually some cutting edge vendors out there that are claiming that employers can utilize a cash price after the fact. But candidly, it's messy. It's it's disruptive. But the clarity is, I mean, it is crystal clear in law. Everybody understands how it works if you pay at the time of service.
Yeah, because, I mean, I tell people all the time, they get a surprise bill, they're on the wrong plan, they made the wrong decision, or it's just whatever, the best that their employer could offer was, maybe a high deductible health plan. And they call, say, can this be right? I'm like, absolutely. It absolutely can be right. I can still tell them, we'll call the doctor and say, I can't pay this. What would you accept if I just sent you a check today to make this go away? That's essentially like paying cash, but it's a vulnerable situation. You don't have any right. There's no, the doctor does not have to accept that, right? You probably already signed a document in the office that says you can bill my insurance and I'll pay. So the time to do this, and that's why technology is so important, right? You want to be able to take this and make it user friendly. Yeah. At what point are all of the services that you are getting involved with services that require pre-certification so that there's that trigger?
Not all, but many. Yeah. Not all.
What's an example, like what's an example of one where it could work, without the pre-certification?
Well, I mean, pre-certification just depends on the plan, right?
Right.
So we have clients that certify or that require pre-certification for all outpatient surgeries, and we have others that don't. That
Right.
it can work in either environment.
The trick is just knowing it happens beforehand, right? There's got to be something, something there.
And incentives and enhanced primary care. I mean, there's a number of strategies that can help facilitate identifying cases pre-service.
Well, we're already, I can't believe this has probably been the quickest show in my mind. It was already up on the hour. So this has been great. Hopefully this is helpful to employers out there, plan sponsors, HR directors, whoever, this is just, for me, it's another layer of that onion that when we peel it back, so it's like, wow, there is an entire universe out there outside the status quo. And for me, it's motivating me to keep learning. So happy that we connected. And I really think that the days of the managed care networks are coming to an end. I think that they've been exposed for their lack of value, especially over the last 15 to 20 years. I don't necessarily want to see the companies go out of business, but I want to see them do business, differently. And that's only going to happen if the consumer takes their business elsewhere. They'll follow the money.
Yep.
Like anything else in life. So you've been amazing. How could someone contact you? LinkedIn the best way, or?
LinkedIn works great. I'm also happy to share my email address. It's my first name, Korb, K-O-R-B, at Asserta Health, ASSERTA health.com, and would welcome additional questions and dialogue.
Yeah, awesome. This is going to be, it'll be up on our website pretty soon. There'll be we have the spotlight page for the video version. We'll be on most podcast sites within the next week or two as well. So I really appreciate it. Thanks for taking the time out of your day today to join me, and I'll be talking to you real soon.
All right. Take care. Thank you very much.
Take care. Bye-bye.
Bye-bye.